Hello, this is Stevix again. I know you have watched the first video or the first two, the first video of AEGIS Security Architect, and I'm going to skip the introductory part of it when I was explaining what AEGIS can do to us for us. So in this video, we're going to go detailedly on how AEGIS can be used in healthcare sector. So we're dealing with healthcare sector not because it's the only one. AEGIS can work similarly with the 16 critical sectors in our country today. So we're going to go step by step and answer some detailed questions in real time. So the scenario is going to be like in real time so that you can really see how this can be helpful to you. Without further ado, let's get going. All right. In order to establish this, let's establish communication. So I'm going to say hello. And once they will ask us what we want to do, I'm going to put in the information about healthcare. Then from there, we're going to ask those questions that we need. Good. So we have hello. He said, hello, I'm AEGIS Security Architect. My mission is to help you design, validate, and document secure, scalable, and compliance-ready security architectures tailored to your organization goals. I specialize in generating security architecture diagrams in multiple formats, and those are the format. He gives us category tools that we can use to view our code once it is generated. So he asked, how may I help you today? So we are going to give that case scenario, and we are going to list all what is available. So we have given a use case scenario. A large multi-hospital health system wants to modernize its electronic health record environment, implementing secure telemedicine, and ensure full compliance with HIPAA, HITECH, FDA, post-market guidance, IEC 62443, ISO 27799, NIST 866, and 21 CFR Part 11. The organization also has the following: aging medical devices running Windows 7, past risk imaging workflow, 100 of third-party cloud vendors, BAUM, VLAN with limited patching options, tight uptime requirements for surgery and ICU, sensitive research data, genomics plus AI models, and telehealth platforms with high PHI exposure. Those are the things that are available with the internet. So let's give this information and start asking our questions gradually. So our very first question. Our very first question will start with a constraint. So as you can see, he has identified that I'm requesting a security architect design for home care, public healthcare sector. But before we proceed with this high assurance design, I must confirm your commitment to proactive security standard. Mandatory pre-designed user question. Your design must proactively implement all applicable security best practices, including but not limited to. So he's saying that our design will include most of this, right? But it doesn't mean that all of it will be applicable. But these are just things that we should know that the design is going to consider. Given the way we ask and depending on our question, then that is it. Yes, I agree. But I have some follow-up questions before the design. quickly. He said, excellent. Acknowledging your commitment to this proactive security standard is the first step toward resilient healthcare infrastructure. Please go ahead with your follow-up questions. I am ready to discuss specific challenges such as security legacy, Windows 7, and so on and so forth. But that's not what we have in mind. We want to expose this agent in so many ways. So the first question that we're asking the agent is about constraint. And that's the question. What unique cybersecurity constraint must a hospital consider when modernizing its EHR environment? So he's doing the work. All right. There are so many questions, so we're not going to be deep with the answers. We're going to be surfacing the answers so that we get to the point. But all of you guys will understand the production. However, modernizing an electronic health record environment introduces a unique set of constraints where patient safety often dictates security architect decision, unlike standard enterprise IT, where confidentiality is king. Healthcare operates on an HITECH, availability, integrity, confidentiality, which is the same as the SEER tribe. Meaning, if a security control delays a surgeon or blocks a life-saving command, the architecture has failed. Here are the unique cybersecurity constraints your hospital must consider. The first one is unpatchable legacy constraint, which deal with the Internet of Things, Internet of Medical Things. As we mentioned, you mentioned aging medical devices running Windows 7. In a standard environment, you would upgrade or replace them. In healthcare, you often cannot. That's the first one. And under it, it mentions the FDA validation lock. And the constraint is you must secure devices you cannot patch. The next one is architectural implications. This forces a microsegmentation strategy. This device must exit in entirety VLANs with strict access control lists that allow them to talk only to specific packs RIS server they need and nothing else. The next constraint is the break glass availability paradox. In an ICU or surgery suite, a doctor cannot wait for a complex multi-factor authentication prompt or a lock account reset during a code blue. Constraint. Security control cannot impede immediate clinical care. Architectural implication. You need context-aware access control. Standard mode, emergency mode. Next, the third one is high velocity data interoperability. Very important in that context. And in this case, he talks about constraint is high velocity of login, logout event dosing per hour leads to multi-factor fatigue. Architectural implication, implementation of single sign-on pair with proximity badges, tap and go. The badge locks the user in. The removal of the badge locks the station immediately. The next one is supply chain and cloud risks. We're all familiar with supply chain and cloud risks. And the next one is sensitive research and genomics data. Genomics data is static. You cannot change your DNA like a password and highly identifiable. Constraint. Standard de-identification techniques often failed with genomic data. So architectural implication, research environment, which is genomic stroke AI, must be air gapped or logically isolated in a secure research enclave with no ingress to the general internet and strict data loss prevention controls that blocks bulk export. So this is what he has for that first question. And I hope this first question actually exposes the constraint, how uh, AEGIS Security Architect could help in identifying constraints when building uh, a security architectural design. So we're going to move to our next question. Our next question is going to show how these constraints affect the architecture design for EHR, telehealth, plus medical devices. Bam. So it is giving us the information we need. Let's be chilling, or we can start discussing where it goes about. So this architectural design directly addresses your constraint by moving from a flat network to a zero trust zone based architecture. The core strategy is isolation and control interoperability. Operability. We isolate the risk asset Windows 7 Internet of Things while enabling high-speed access for clinicians and secure inspected pathways for telehealth and cloud vendors. The first one is the architectural strategy is the zone defense model, which is broken down into the biomed legacy zone, the clinical operations zone, the telehealth and interoperability edge, the research enclave air gap logic, and the visual. This is a kind of a visual infrastructure that is giving us that that's how they can use to solve the problem. There's a link. But we're not yet there. We are going to come back there because we want to answer all the questions. I think we saw this one, bringing the architectural diagram wasn't really a problem, but we have seen that in our previous video. So however, we are interested to know how this agent can help solve this problem, the constraint that we have identified in this particular scenario. So we're going to move further. We will not look at the design, but we're going to see the design later. We're going to move further to ask our next question. So in this our next question, we are going to ask our agent to map each architectural decision to healthcare regulation, including HIPAA, HITECH, FHIR, ICE 62443, and NIST. Let's see what it gives us. So that's doing the mapping. Let's start looking at the mapping from the beginning. This mapping validates that every architectural decision is not just a technical preference but a regulatory necessity. By implementing these controls, you move from checking boxes to a defensible security posture that satisfies auditors from OCR, HIPAA to FD, and Joint Commission. Now, these are the regulation metrics that he has produced. Biomed Legacy Zone, Windows 7. That's the first. We have the FDAL, the ICE, the HIPAA, and the NIST 866. That gives us all the mapping and how the architecture complies, the requirements that we need at each of the stages or that we need to implement. The next one is the clinical operations zone. We have the HIPAA, the NIST, we have the ISO, and yes, the clinical area we have the ISO, which also gives us the requirements and how it applies. And then the next is telehealth and interoperability edge, the API security, where we have the HITECH, the HIPAA, the NIST 600, and the FDAR. Also give us how it applies. And the research the research enclave where it gives us all the stuff, and the CFR, he went about to give us the requirements and how it applies to the architect. And lastly, he now gave us general architecture logic and monitoring. He gave us all this, and each of them explained how it applies, and he gave us a little ready summary. Now we can now confirm that this agent can help map actual decisions to healthcare regulations when asked to do so. Even when not asked to do so, it can proactively produce that. So let's go to our next question. Our next question will be demonstrate zero trust applied specifically to a multi-hospital clinical environment. As fast as speed of light. So it is giving us the information that we need. So we can start going down while it's working. In a multi-hospital environment, the traditional castle and mouth security model fails because the perimeter is everywhere: cloud, remote, clinic, mobile, doctors, and Internet of Things devices. So zero trust shift the paradigm from trust but verify to never trust, always verify. That's a concept that we all know. Here is how we apply Here's how we apply NIST 800-2070 trust principle specifically to your distributed clinical environment. The core concept is the policy engine, which he went further to say in this architecture, no user or device connect directly to a resource. Instead, every request goes through a policy enforcement point. The policy enforcement point asks the policy decision question: should I let this happen? The policy decision point makes a real-time decision based on context, not just password. So that's why we have the zero trust use cases in your hospital. He has given us the roaming clinician identity context. We also have the toxic legacy device network isolation. And we have the just-in-time vendor supply chain. And it also gave us the zero trust logical architecture design. But that's not what we're looking at now. We're going to look at that one later. And it gave us, after that, it gave us how this meets your constraint, the above. So it gave a constraint zero trust solution, multi-hospital identify in the perimeter. It does not matter where hospital building the doctor is in. The policy follows the users, not the network cable. So on and so forth. So we can have a time to look at that together. Implementation strategy for zero trust. This is the implementation strategy for zero trust, which the first one is identity, the protect surface, and the next one is map flow. The third is architect, the policy, and then the fourth is enforced. Now, let's go to the next question. And I hope this one really exposed to you guys how zero trust could be applied specifically to a multi-hospital clinical environment with no doubt. Let's move to the next. In this next step right now, we are designing. So design the HIPAA HITECH compliant telemedicine architecture with turn servers, ER integration, and PHI audit logic. We are designing now in this case. So when we design, we are going to view our design in this section. Now let's put it in. Go. So the design is going on. It's listing the regulations. Partitioning each section into group bring out the regulations for us to see. All right, that's it. That's given us everything. I think this part of the question is about the design. So we're going to copy this design to our Mermaid live, and then we're going to view that design there. However, before we go to copy, let's see what was designed for us to certify HIPAA and HIPAA. This is what they made it. The media, video, audio is encrypted. They went further to signaling metadata and ePHI data, audit logs, then the architectural overview, which we will use split plane architecture, control plane, and data plane medium. We went further to give us the key components, which is the turn tune savers, the signaling savers, the API gateway, and the audit vote. Now, this is a design that I've given us, which we are going to view. Let's just go straight. We can click here to go here, but if I click here, it's going to take me to another account, which I've not subscribed yet. So, security controls and compliance mapping. You have the media transmission, 10, and all the one that we have seen above. Also give us a regulation requirement and implementation that has been given to us. Every implementation is there. And then we also have the EHR integration, the patient data. Also, we have the regulations. I have the audit logging, what to log. And in this area, also have the regulations. And then implementation checklist, which is the checklist that we have here. Now, in this slide, all right, we're going to view our design. So I'm going to click at the link that's taking me here, and I'm going to start, and I'm going to press our design. As you can see, that's a design that was designed for us. If we zoom, we're able to view the design. Let me zoom again. You can see public internet and remote doctor, laptop, patient device, browser. We have the encrypted media, DTLS, and so on. Encrypted media, also beautiful stuff. We have the DM Zoom, Edge. We have the load balancer with the web, with the WAF. We have the 10 saver and the cluster, code turn, and Twitter. We have fetch, med JSON that goes down to the API gate. We have the signal saver work this thing, and we went for that to give us the audit layer and so forth. So this is a multi-design that we have seen. We have the signaling saver web socket and so on and so forth. So it went further to the ePHI interface engine, where we have the ePHI database. So that's a design that has been proposed for us, given our present requirement. So we have seen the design, and we have seen what was produced for us to see. So we are good to go, and we can move to the next question. Our next question in this regard will be asking to show how the PACS, RIS, and the DECOM traffic must be secured in the hospital network. Bam. So it's giving us a diagram, the design to show. Show means demonstrate, right? So let's see what we have from it. Before we go to view the demonstrate that our agent has given us, let's look at what were the consideration? Architectural strategy, the DICOM wrapper model. We cannot simply turn on inscription for a 15-year-old MRI machine. Instead, we use a proxy wrapper architecture. Modern modalities, legacy modalities, teleradiology, and so on and so forth. So we're going to see how it has shown us from our architectural design how the DICOM and the past RIS must be secured in the hospital network. So let's go together and view that together. All right, we're going to copy this design code to see what has been designed for us to provide how the DICOM traffic must be secured in the hospital network. However, I've introduced you guys to the first one that we're talking about, which is the Mermaid on the ecaslax.com app. This one is actually free. I'm going to introduce you guys to another Mermaid website, which that one is not free. That one you really have to pay. And that one is good. It's good in the sense that it corrects codes. If the code comes with a syntax error, it will help you correct the code for you. So the AI can help you fix the code for you. So this one you need to upgrade. You need to be paying monthly or yearly. Good. And this one we can actually close this to discuss the project, and we see how it is displayed on the screen is more preferable than the first one, but you have to pay for this one. You have to subscribe. So you can see the biomedic van, it has improved it. Legacy MR, it has put this one in one internet container, and it went further to the DICOM TLC before going to the internet firewall NAC of the network core, and they have the DICOM TLC port. So it went further to give, it talks about a remote area with radiologist workstation, and then it gives us the DICOM again and the inspect and route. So this is what they improve or to make sure the network is always secure. This is how the architect is gonna look like. So as I said, you can always use memberchat.com, which you have to pay for, or you use a free one. All right. So we are back into our chat. Now let's proceed with the next question. Let's proceed. So the next question is, show a healthcare specific incident response workflow for a ransomware attack on ePHI. So it's designing the workflow for us. Good. That's designing the workflow for us. Remember, the question was, show a healthcare specific incident response workflow for a ransomware attack. And the very beginning was key differences in healthcare IR, code dark protocol, biomed isolation, and regulatory clock. Now, so we have to go take this our workflow and see how it goes. Some people will really understand this in this way, but let's see if we can have it in a workflow diagram. So we're going to copy that to the Mermaid.com so that we can demonstrate that whenever it has some mistakes, they will be able to have it rectified. And since we are here, this is the initial project that we had before, and We are going to put it there and then see.